Okay.
And you can share later once you welcome everyone.
Welcome everybody. I welcome all the speakers daily and discussants.
Are we live?
We are live now, please.
Yes. Good evening, everybody. I welcome all of you for this series of webinar A to Z of ISMSICS. I'll be starting my presentation. Train ophthalmologist in Good evening, everybody. Respected seniors and my dear colleagues. I, Dr. Anil Shah, President for Maharashtra chapter, welcome all of you to this wonderful series of webinar that is A to Z of manual small incision cataract surgery. Today is episode 17, part 4, and the title for today's episode is Adaptive Approach to SICS and Nucleus Manipulation, Illuminating Different Perspective, a Nucleus Management Technique. The aim of SICS webinar is to educate, to provide participants with comprehensive understanding of SICS, including technique, advantages and challenges, to empower, train ophthalmologists in mastering SICS technique, ensuring proficiency in handling diverse cataract cases, to exchange the knowledge, facilitate discussion among the experts to share best practices, tips and insight, to enhance patient outcome, focus on improving surgical precision, efficiency and recovery time through SICS, to promote innovation, show novel technique, creative solution for challenging cases. Here are a few important remarks about this. Surgical success lies in adaptation. Each eye presents a new challenge and each challenge demands a refined approach. A skilled surgeon doesn't just follow the technique but adapt them to the need of the patient. There is no single best way. True progress comes from exploring multiple perspectives. Every surgeon brings a unique vision to SICS and together we can illuminate the future of cataract surgery. Here are a few photographs showing nucleus management technique optimizing surgical success. And for this webinar, we have chairperson Dr. Prakash Marathe, Dr. Inder Mohan Rastogi, Dr. Ranjana Pandey, and the speakers for this webinar who are expert in their field with the best of their knowledge and experience, Dr. Vinayak Bagdi, Dr. Amarjit Singh, and Dr. Deepak Meghur. And to discuss this topic, we have discussant who will argue and debate and dialogue. We have Dr. Amit Mahajan, Dr. Kuresh Maskati, Dr. Parikshit Gupte, and Dr. Anand Pangarkar. And the moderator who will preside over the webinar, making the discussion enjoyable and effective, we have Dr. Aarti Heda and Dr. Ruchita Machwe. I am thankful to chairperson, speaker, discussant, moderators, and participants for sparing their valuable time and making this webinar a grand. I'll hand over to Aarti for.
Yeah, so good evening, everyone. I welcome you all to another wonderful evening of learning. Why am I saying so? Another wonderful evening of learning. We have been discussing nucleus management in SICS since last 3 sessions, and today is the 4th session wherein we have tried to cover all possible options of nucleus management in SICS by the experts in the field. And today will be the last session for nucleus management. So with this, I just invite the office bearers of ISMSICS, Dr. Amulya Sahu sir, founder chairman of ISMSICS, Dr. Jagannath Buramani, executive chairman of ISMSICS. They'll be joining us shortly. Then we have with us Dr. Parikshit Gupte sir, who is vice chairman of ISMSICS. Over to you, Parikshit sir, for words of wisdom.
Ma'am, I'm a discussant, so I think I'll discuss at the end. Thank you for giving me the opportunity.
Fine, sir. So we have with us Dr. Barun Nayak, sir, who is president of ISMSICS. Over to you, Nayak, sir.
Yeah, good evening, everyone. And I am really so happy that ISMSICS is doing so much of educative work, and webinars were so useful It's always very, very interesting and impressive once you attend these webinars. So I wish all the success to these series of webinars. Thank you very much.
Thank you so much,
Thank
sir.
you, sir.
We have with us Dr. Prakash Marathe, sir. Sir, over to you. He is chairman of Maharashtra chapter of ISMSICS.
Good evening, everyone. All the chairpersons, discussants, and speakers and delegates who have joined for this wonderful webinar series. I think it is the great activity of Maharashtra chapter under the presidency of our friend Dr. Anil Shah. It is almost the university syllabus of ISMSICS, and that is related to SICS. What name he has given is A to Z, but nowadays I have added not only A to Z, but even alpha, beta, gamma we are going to cover. Starting from incisions and then nucleus management and visco and skeletal and whatnot, equipments, everything. I think every aspect is being discussed in detail, and that is definitely beneficial to each and everyone. So I think seniors as well as general ophthalmologists, SICS surgeons, even phaco surgeons and newcomers in ophthalmology, everybody is getting benefited. So I wish all the success and all the best for even this webinar. Over to you, Dr. Arti.
Thank you so much, sir. With this, I invite Dr. Ruchuta Machwe to take over the session. She'll be moderating the session with me. Over to you, Dr. Ruchuta. Ma'am, you are muted.
Am I audible?
Yes, you are.
Yeah. I'm Dr. Ruchuta Machwe, Executive Committee Member of ISMSICS Maharashtra chapter, and I'll be co-moderating with Dr. Arti. So today we have got eminent ophthalmologists as chairpersons. Dr. Prakash Marathe sir is Chairman Maharashtra chapter ISMSICS, Managing Committee Member AIOS 2020-23, Past President MOS, Trustee and Past President Pune Ophthalmology Society and IMA Pune. The next chairperson is Dr. Anil Shah. He is President of ISMSICS Maharashtra chapter. He is a private practitioner in Nandurbar since 1986. He has got research awards from MOS for snare and large foldable eyes for MSSAS, modified intracystic implant for DCR, MOS Best Research Private Practitioner Award. Our third chairperson, Dr. Inder Mohan Rastagi, is Professor and HOD, Department of Ophthalmology, World College of Medical Sciences and Research, Haryana. Is the Director of Triveni Hospitals Private Limited, Gurgaon. Is a recognized PG teacher by NMC. And he has been awarded with various awards. One of them is Gold Medal by ISMSICS. Our fourth chairperson is Dr. Ranjana Pandey. She is retired professor at BJ Medical College and SGH Pune. She served as teacher for 35 years. She was a UG and PG teacher, DNP examiner, and she has presented various national and international papers. So today I'm very happy to know that we have got eminent speakers as well as people who are experts in their surgical skills, and these are our three speakers. The first speaker is, please project the slide. Yeah. These are the people with great surgical skills and teaching experience. So our first speaker is Dr. Vinay Badgi. He's MS Ophthalm from Dr. VM Medical College, Solapur. Practices at Eyesight in Dombivli East, Thane since 2002. He worked in Municipal Eye Hospital, Kamatipura, Mumbai for 10 years. He learned phacoemulsification technique in 1996 while working at Municipal Eye Hospital and later developed SICS techniques. He presented papers, videos. He has conducted various instruction courses in various state and eye advanced conferences. Our next speaker is Dr. Amarjit Singh Patwalia. He is a postgraduate from PGI 1990. He developed passion for manual SICS in 1997. He introduced many innovative steps in nucleus management in SICS. He holds Limca Book of Records, India Book of Records for performing 2.8 mm SICS for the first time in the whole of North and probably first in the world in 2018. He has got publications in International Journal of SICS on SICS grading system in topical SICS 2012. He introduced SICS first time in the International Conference of Canine Cataract Surgery in dogs. He has got innovation with Patwalia butter knife chopper in advanced SICS 2024. Our next speaker is Dr. Deepak Megur. He heads the cataract and glaucoma departments at Megur Eye Care Center, Bidar, Karnataka. His specialization in complex cataract surgeries. Is passionate about teaching and sharing surgery skills through his YouTube channel and website. He's a past scientific committee chairman, KOS. He's reviewer of IGO, and he has got various awards and recognitions like ASCRS 2023 Best Video Award, CS Reshmi Overall Best Video Award, AIOC 2020, Best Paper of Session Cataract AIOC 2018, so on and so forth. So I welcome you all for giving today's presentations. And to make the presentation and our discussion more meaningful and more helpful and have take-home messages, we have got discussions, and Dr. Aarti Heda will be introducing the discussions. Over to Dr. Aarti.
Thank you so much. Moving on to introduction of the discussants, we have with us Dr. Quresh Maskati sir, who has been president of all prominent societies like AIOS, MOS, BOA, Cornea Society of India. He was chairman of ISMSICS from the year 2017 to 2019. We have with us Dr. Parikshit Gupte sir, who is vice chairman of ISMSICS. Then we have with us Dr. Anand Pangarkar sir, who is scientific committee chairman of Maharashtra chapter of ISMSICS and has been engaged in teaching as honorary associate professor for last 25 years. Last but not the least, we have Dr. Amit Mahajan sir, who after completing FACO fellowship from Bachuali Eye Hospital in Mumbai, started a private practice in town called as Chalisgaon since April 2006. And has been an anterior segment surgeon and phaco surgeon. He might not be able to join us because of some personal reasons. Okay, so with this, we move on to the actual session. So with this, I invite our first speaker, Dr. Vinay sir, to share his presentation. Over to you, Dr. Vinay.
Good evening, everybody. Am I audible?
You are audible, sir.
Thank you. So this is my topic. Next. I thank all the office bearers. What is new in my technique? It's 3 mm to 4 mm tunnel. I use scissors to cut the nucleus. The nucleus is cut into small pieces, not necessarily bisection or trisection.
Sir, have you shared the screen?
Sir, your screen is not shared, Dr. Vinay.
Yeah. Screen sharing has to be done, please.
Okay. So thank all the office bearers, Dr. Sahu and everybody. What is new in my technique? I use the tunnel 3 mm to 4 mm in width. I use scissors to cut the nucleus in the bag and anterior chamber combined. I cut the nucleus into small pieces so that they come out through the 3 mm tunnel, and I don't restrict myself to either bisection or trisection. I cut the nucleus up to 8 to 12 thin pieces, which would come out very easily through the tunnel. And I use an visco AC maintainer. So this is the cross section of the eye. So you can see the cataract after XC series hydrodissection procedures are done, and now we have the hard nucleus in brown shade, the epinucleus in green shade, and the cortex in blue shade, and the posterior capsule. So I use this space combined anterior chamber and the bag to manipulate the nucleus. I place the nucleus, I tilt the nucleus in this position. So after the hydro procedures, I use the scalp when set needle as a visco maintainer, this one, and a Sinski hook, and I tilt the nucleus out of the bag. I have designed this. I have made this picture, and this is the tunnel. We can see the nucleus being tilted out. Half portion remains in the bag, and half portion is right in the AC. I distend this bag with a lot of viscoelastic so that the volume increases. Now I can introduce the scissors through the 3 mm tunnel, and as I introduce the blades and I pass on around the nucleus, each blade on one side. So you can see one blade seen and one blade which is behind this portion of the nucleus, so that it can cover up to 5 or 6 mm width of the nucleus. And then in that position I would cut the nucleus into one piece. Now further again I'll bring this nucleus in the center, and in the similar fashion I'll cut into smaller pieces, and they would be delivered out of the tunnel just by compressing the lip of the tunnel. This is the design of the video. Scissors. It has the fulcrum or joint which is about 2 mm width, and the blades are about 9 to 10 millimeter long, and the gap between these two the viscoelastic maintainer is actually a 21 gauge scalp pen set, and I bend the tip of the needle in this fashion, and 5 cc syringe of viscoelastic is connected to the other end, and my sister would hold it and inject whenever I instruct her or when the AC becomes slightly shallow. Now I'll present my first video, slicing in the cataract, white cataract. Please bear in mind that as the video is 2D, the nuclear fragments and instruments may appear a bit near to the endothelium, but they are separated by the viscoelastic. So I'm doing a sclerocorneal temporal tunnel, 3 mm, just completed the rexis. So white cataract. Now I'm inserting the viscoelastic maintainer needle, and with the Sinski hook, another pole I'm just lifting it up and supporting the nucleus with the tip of the viscoelastic maintainer, that is the 21 gauge needle. Now I hold it in the oblique position. I embed the tip of the needle in the nucleus so that it's stabilized.
Video is not running, sir.
And now I'm cutting the nucleus. Video is not running.
So the video is stalled.
Video is not running, sir.
Now video seen. I'll do it again.
Sir, it is seen. There's a little bit of buffer now, but it is seen.
Now.
So it's paused. Yeah, now it's better. Maybe it has just started
Is it running,
playing.
sir? Dr. Anil? Back check what is back check. Slide everybody.
It's not properly running, it's too slow.
But is it seen?
Yeah, it is seen.
Okay, now I'll run it again. Now?
You make it full screen, sir.
Big screen? Big screen.
It is paused, sir.
Now is it seen?
You play it, yes.
Yes. Now okay?
Is
it seen?
It is seen but not moving, sir.
Okay.
It's seen as different steps and getting buffered in between, not as a continuation.
So can you click on the screen and play? Just click the play
No,
button
I
on the
think
screen.
the internet speed is very slow, I think.
Yes, the internet speed is slow.
Maybe. Now, can you see the nucleus being cut with scissors?
Sir, even your video is freezing.
Sunil, can we ask sir to pause his own video and then see whether the connectivity comes out better?
Okay. How is it now?
You can continue like this, I believe.
Yes, but it is better now.
Okay. So I'm holding the nucleus with the tip of the needle, scalpel set needle, and the visco is being injected continuously so that my hand is spared and the AC is formed all the time.
Make it
cutting the
slide show, sir. Slide show पे कर दीजिए इसको.
Now is it see?
It's seen, but yes.
Yeah. So with the tip of the scalpel set, I engage the nucleus and I use the scissors and the blades are passed around the nucleus and I cut it. And the AC is maintained all the time with the viscoelastic being injected by the sister. So once the piece is cut, I just depress the scleral lip of the tunnel, and because of the viscoelastic that tries to flow out through the tunnel would bring out the nuclear piece also. So it just continues. I cut the nucleus, and if I find they are a bit larger, I cut it again. So there is no restriction. And the cut pieces have very smooth edges, no ragged edges, which would easily come out of the tunnel, scleral tunnel, without causing any damage to the architecture of the tunnel. Next. Next video is through 3 mm tunnel. So after I'm doing hydro procedures. In hydro procedures, first I do the hydro delineation because that would guarantee the smallest possible size of the nucleus, one thing. And because you have got support of the zonules, you can complete the hydro delineation better. Followed by hydro dissection. Because I want the nucleus to be free from the capsular bag. I'm injecting enough of viscoelastic. I first did hydro procedures in this case, and now I'm doing the tunnel. Just 3 mm tunnel, sclerocorneal on the temporal side. And I'm doing everything under topical anesthesia. And one point I'd like to mention is I don't use cautery. Little bit of bleeding I can manage. This is the tunnel, and there are no side pockets. I don't require side pockets. Here I use one more device. This is an iris guard. This piece rests just below the tunnel on the iris. Because when I'm cutting the cataract, there is every chance that with every cut, the iris may come into the scissor and that may get cut. And once that happens, then iris prolapse starts occurring, and that becomes difficult. So this prevents iris prolapse also, and it guards the iris from any inadvertent cut of the iris. Now I'm injecting a lot of viscoelastic in the dissected space between the nucleus and epinucleus with the visco AC maintainer tip and the Sinsky tip. I'm just lifting one pole on my right side and lifting it up, bringing in the AC, while the other pole remains in the bag. Again, the AC is filled with viscoelastic, and I start cutting the nucleus. I don't have to hold a piece and bring out. I just press my scleral grip, and with the flow it comes out smoothly. So the remaining portion I just lift with my left hand, left instrument, cut it and deliver it out. So the iris guard that I have inserted just stays there, just below the tunnel. Now again cut it. I just press the iris repositor, the tunnel scleral lip. Normally I use methyl cellulose, but nowadays I'm started using Hylucoat also in between, so that gives very clear cornea the next day. The AC is never overfilled, or the pressure also is maintained, because my wounds are not totally watertight. So even if a little more of viscoelastic is being pushed by the sister, it won't cause a raised intraocular pressure. The AC remains with normal pressure and formed all the time. Now the nucleus is managed. What remains is the epinuclear bowl and the cortex, which I remove it later. You can see the remaining epinucleus behind. And after the nucleus is managed, I remove this iris guard. Because now the role of scissors is over. I have to just manage the epinucleus. Next. The next one. One more case I am showing. Here, in fact, I started SICS in 1997. Before that, I did a lot of phacoes, but I thought we are dependent on the machine, and if you could crack the nucleus into two, we just won the game, because those days only PMMA lenses were available with optic size of 5.5 mm. So I'm just I've reenacted the first trial that I did for SICS. As I done a lot of phacos and sculptings, I thought without phaco I'll sculpt with a needle. I had taken a 18 gauge needle and I started sculpting. I'll just show in this case. Now I started sculpting with this needle. I'm fixing the nucleus with the SICS cube on the other side and engaging and just cutting the nucleus and epinucleus and bringing it up. Now we can see, as in FECO, we do a sculpting and create a trench. In a similar fashion, I have just done it. This I don't do in all cases, but just to show that time what I did, I did this again. Now I felt the trench is not enough, still more I did. I went deeper. Without FECO. Now I just pushed viscoelastic and removed all those cut pieces. Now visibility is very good. Now in the trench, as you would cut in the divide and conquer technique in FECO, I just did that. And I could cut the nucleus into two halves. So I could achieve division into two halves. And I'll bring out one piece out and manage with the scissors. In fact, this is only for showing, because in a small axis to bring out one half is quite difficult, especially if the nucleus size is large. Now I'll manage this nucleus with my scissors. After first few cuts, if the pieces stay bit on cutting them into small pieces and then remove them finally together. And if I feel those cut pieces are moving and just moving out towards the endothelium, then I would deliver them out and then do further cutting. Here I cut them into many pieces, and now one by one they will just come out. You can notice there is no stress on the back, the cornea, neither zonules. And with so much of manipulation, the iris also is not popping out or causing iris prolapse. Now I'm managing the second half. Preferably, I keep the cut edge facing superiorly and the smooth pole facing the posterior capsule. We have to cut the piece only in the longitudinal shape. What matters is the width of the piece. Any length would just deliver out easily. Any piece which is slightly thicker, I would again trim it. So that while delivery there is no strain on the tunnel. The visco is being pushed by the visco maintainer. The pieces are being delivered out. Now in this technique I can manage brown cataract, white cataract, very soft cataract. The technique doesn't vary much. Now I'll remove the epinucleus bowl. I just push fluid again, irrigating fluid in the gap. And many times I am successful in removing the whole bowl of the epinucleus. Now with the viscoelastic syringe and cannula in the AC, I am just pushing the viscoelastic.
In the interest of time, we
yes.
request you to conclude
Yes,
your
yes. Thank you. Thank you so much. Okay.
Yeah. So moving on to our next presenter, I invite Dr. Amarjit Singh sir for his presentation. A quick reminder for our audience, if you have any questions, you can put in the chat box. We will take them up towards the end of the session. Amarjit sir, can you please share your screen?
I think Dr. Badley sir needs
Vinay
to
sir,
unshare.
Vinay sir, can you please stop your screen share, or Sunil, maybe you can stop.
Yeah, someone else is sharing.
Yes.
Vinay sir, if you can just stop your screen share, sir.
Hi, I'll do that.
Yes.
Yeah.
Hi, everyone. Am I audible?
Yes, sir. You are.
And we can see your PPT
All
and
right.
also. Excellent.
Okay, I'll be showing you very, very small and very short videos whereby the emphasis would be starting from incision, which is 6 millimeter, and it goes up to 2.8 millimeter incision. In all these cases, I'll be showing how to manage the nucleus in such cases. This is part one. And part 2, I'll be showing the new advances in manual SICS using Pathwalia's butter knife chopper. So this is the first case, very short. This is 6 millimeter incision, and I'll be showing how to do a phaco sandwich in this case, because this is the only thing. If you learn phaco sandwich, then you can improvise any technique, whatever you want. So this is the nucleus. You bring it into the anterior chamber using only 2 instruments, that is SICS and wire rectus. Just sandwich, press the posterior lip and take out. Clean the cortical matter and just implant the IOL inside the bag. Now the next one I'll be showing you slightly shorter. We make it about 5.5 millimeter incision. And here I'm going to show you how to bisect the nucleus into 2. Using the same 2 instruments, you have to just press it and take out the nucleus. Now the other piece, you can take it out either by a wire rectus or you can do a sandwich technique again. Similarly, you can just clean the cortical matter. I'll be showing it here. And then you can implant the IOL inside the bag. Now comes to the third case. I have reduced the incision further to 5 millimeter. Here I'll be showing how to trisect the nucleus using the same 2 instruments, that is wire rectus and SICS. So it goes underneath. It's very, very simple. You have to just go with the SICS hook, press against the wire rectus. I'll be showing it here. And the most interesting thing is, this is one piece. Go to the other side. This is the second. Now, as you bring the wire rectus out, automatically the center piece comes out. So you are left with only 2 pieces all the time, whether it's a grade 1, grade 2, grade 3, whenever you trisect, the center piece comes out. Now this is remaining. You can take it out either by visco expression or you can take it out with the sandwich technique itself. Now the next one, I have further reduced the incision to 4 point. See, it's very difficult to implant because the size was so small. Now this is 3.5 millimeter incision, a bit hard cataract. So you do the capsulorhexis in such cases. Now the crux here is that when you bring the nucleus out, you divide the nucleus into 2 and bring both the pieces at the tunnel. I'll show you. Bring both the pieces. As you take it out, so there is a fracture at the tunnel. Now the remaining 2 pieces, they are very, very small and you can take them out one by one. Since the incision is small, so you have to use the injector because the lens is not going to go in. After this, there was an innovation. I was just carried away by so many things, so I wanted to go for 2.8 millimeter incision. So here I have also invented a gauge so that you can see at the end. I'll be showing you the internal lip of the cornea, the size. It is exactly 2.8 millimeter incision. I'll make it a bit faster. Okay. Now, once the nucleus is out, same way you have to bisect. Now, after bisecting, if you try to bring the nucleus out, the wire rectus will be totally empty. You won't be able to bring it out because the size is so big. This means the nucleus has to be further subdivided into 4 or 5 pieces. Now, look at this. This is not an elegant surgery. See, I'm going in and out again and again. Though with the experienced hand, you might have very less of complications. I'll be showing you first. Look at this. There is a bit of edema in the upper part. Center part of the cornea is almost clear. And then you inject the IOL inside the bag. Now, this is the gauge I was telling. This starts from 2 millimeter, then 2.2, 2.4. It goes like this. So I'm going to put it inside. This is 2. 2.2, 2.4, 2.6, and 2.8. I'm going to push it in. It's not going in. So the size of the incision is 2.8. This means the internal lip is not more than 2.8. Now look, this is the first post-op day. These are all the cases which I have done. Then I'll be showing you the 2.8 millimeter incision, the 10th day post-op. These are all my cases with different sizes. Now this I was talking about, I called it as a hybrid phaco. Let me enlarge this and show you. Look at that. Hardly any scar, anything is visible. Cornea is absolutely clear. Vision is absolutely fine. Now, let me share another video. Where is it? Sorry. How to close this? Share. Yeah. Now, we have been doing surgeries and we have mastered almost all the steps, starting from the size of the incision, the shape of the incision.
Sorry for the interruption. We are yet to see your presentation now.
You can't see that?
Not yet, sir. Not yet.
How to do that?
So you can stop the screen share and share your screen again with the presentation open.
I have to stop the share?
Yes.
Okay, I've stopped it.
Yeah. So now you can, if your presentation is open, then you can share it again.
I can share it again like
Yes,
this. This is okay?
So it is being shared. Yes, we can
Oh,
see
that's
it.
great.
You can just do it full screen and then we are good to go.
Yeah, it's fine now. All right. So we have
so just go on the full screen mode. Yeah.
I can't see the full screen one. Where is it?
Sir, in the lower bottom, or you can just go on the slideshow and put it on the full screen.
I can't see it. Where is the slideshow now?
The upper row.
There are the
upper right, sir.
You
go
have
in upper right and there is
upper
square.
right. Okay.
Upper right and
Show
square.
meeting slide control. But I have got videos also to show in this.
So
Go
that
on
will
that.
the present with the slides, the videos will automatically come up.
So
Just
it's written slide control. I should press this?
No, there's a slideshow written there.
No, just magnify it. No, sir. It is on the right corner. There is a square. After that cross, there is a square.
Yes.
You just click it.
Okay.
No.
The other one.
No, that one only. You click it.
Okay, I'll do it again.
You make
you do it again.
If you have the videos as a separate file, I think you show it as a separate file. That will be easier.
No, I think it will be coming in this only. Now it's okay?
Yeah, this is okay, sir.
This is okay. Now,
you make it full
since we have mastered almost all the steps in the manual SICS, but still we have surprises of astigmatism. As such, astigmatism is not a problem, but the only problem is its stability. So if you are doing a manual SICS, you cannot predict even after 4 weeks or after 6 weeks that how much is the astigmatism which is going to be there at the end of the surgery. This is number one. Number two is the reproducibility. If there are 2 cases and you want to give them minus 0.75 in both the cases, it's not possible in SICS. Now, the only reason behind this is the culprit, which is not in our hand, that is the scleral healing. We have mastered almost all the steps, but scleral healing is not in our part. So what my hypothesis says, the Pathwalia's hypothesis, it says that do not touch the sclera at all. So why to touch the sclera? Just fiddle around with the cornea. And if the incision is less than 3.5, the astigmatism will be stable. It is reproducible. So many of the, we have got journals and so many statistical evaluations, they are there because we used to do phaco before 3.2 millimeter incisions, and the astigmatism was very much stable, about 0.75, 0.5 in different scenarios. Now, question comes, why we need a small incision? In cases of manual SICS, you are creating an astigmatism, and over that, if you are putting a toric lens, it's a disaster. So this means in cases of manual SICS, you cannot go for multifocal IOLs, you can't go for EDOF, you can't go for ICLs, you can't go for toric IOLs, and then there comes the nomograms you have to follow and do. Secondly, how to go about. Why there was a need of Pathwalia's butter knife chopper. Now I'm going to show you something which is very, very interesting. So this was a case of almost grade 3. I was trying to trisect. Now see, there was a sudden jerk. I went inside. Look, within fraction of a second, see the jerk, and it just slips. Now go to the other side. Similar conditions. As far as the lower grades of cataract are concerned, I am not bothered about this. But what about hard cataracts? It will be so difficult. Now I'm going to show you another one. Now, this was a case of Argentinian flag. The posterior capsule was totally unsecured. The nucleus was very, very hard. And I tried to bring this nucleus through 5.5 millimeter incision. I wanted to bisect it so that there is no vitreous loss. Just have a look. It was so hard. I was pressing it with the SICS as if the SICS is going to break. Now see what happened. And it just stuck, hit the posterior capsule. There was a vitreous loss. And ultimately, the nucleus was delivered, the anterior vitrectomy was done, and IOL was implanted in the sulcus. So this means you need to have something which is very sharp, which is very easy to use, so that you can divide the nucleus with the ease with better results. Then I thought of inventing a Patwalia's butter knife chopper. Now, this was a case when I used scleral incision. Now, remember, I told you the corneal incision has to be there. Now, this is grade 3 again. This is the Patwalia's butter knife chopper. It is very, very sharp underneath, which is made sharper with the laser. Look at that. You have to just place it over it and give it a scratch. That's it. It's done. Now, I'll take out one piece. Look at the margins of the nucleus. They are very, very sharp, very easy to take it out. And then I got the guts to do it with 3 millimeter or 2.8 millimeter incision. This was the first post-op case with 3.2 or 2.8 millimeter incision. I'll just show you. Oh, let me just mute this. How to mute it?
Butter knife chopper.
Where is the volume?
2.8 and 3 millimeter incision.
But it's there where the timing is being.
Okay.
Yeah.
I got it. Now, look at this case. This was, as I told you, yeah. So this is the side port. Go inside. And after this, you just stain the capsule, do the capsular rhexis. I'll just go forward because of lack of time. This is the main incision which we have made, the capsular rhexis. And now you can see the nucleus is out. Okay, here I wanted to show you how this Patwalia's butter knife chopper works. Now, since the incision is small, I have to trisect it. No need to go for 4 or 5 pieces because already 3 millimeter incision, the nucleus is roughly around 8 to 9 millimeter incision. If you make it 3, easily this can come out one by one through 3 millimeter incision. Now, this is one. Go to the other side. Just place it and give it a scratch. Now, these pieces, they are horizontally aligned with the wound. Now, as you bring the wire rectus out, the centerpiece comes out. That's it. Then you have to go put your visco. And similarly, you can just take out pieces one by one. After cleaning the cortical matter, now here there is a bit of peeking because there is a leakage. So it doesn't matter. I can always hydrate the wounds later on. And here goes the injector. And this is the IOL. And that's it. Now, in all my cases, at the end of the surgery, I use a manual keratoscope to see the first Purkinje image, whether the Myers, they are circular. If they are circular, I'm very much satisfied. If not, then I can manipulate with the side port so that it becomes circular. So after hydrating, just see the first Purkinje image. You can see the vision. It's absolutely circular, and I'm very much satisfied. Now, this is the first post-op case. You can see that, how it looks like. And this is the 10th day. Look at the incision marks. So similarly, I have done, these are all the cases, my first post-op. This was a very hard cataract, where you can see a bit of corneal edema in the upper part, and look at the 10th day, it's absolutely fine. This one which you are seeing, this is a temporal incision which has been done, again a clear corneal incision. So I have done about 14 cases, and it's about 4 months. The vision is absolutely stable, and the astigmatism is between 0.5 and 0.75. So, just to sum up the whole thing, I would like to say that Patwali's butter knife chopper is an excellent tool in the management of advanced manual SICS. Why? Because the number of steps, it is reduced. You are not dealing with the sclera at all. Number 2, the size of incision is very, very small. Number 3, you can implant and go ahead with multifocal IOLs, with toric IOLs. And secondly, the most important thing is no need to calculate, you follow the nomograms or so, because this is already 3.2 millimeter incision. It has already been time and tested. Thank you so much.
Thank you, Amarjit sir. It was a great presentation with great photographs and videos. So I invite Dr. Deepak.
Unmute yourself. I can't.
Next, I invite Dr. Deepak Megur sir for his presentation. Am I audible?
Yes.
Yes.
In this case, intentionally imperfect.
So thank you for the opportunity. I'll be speaking on in the bag nucleus division. So
Forming a slightly bigger.
So now we just saw Dr. Amarjit display the way to divide the nucleus in the antechamber. And this is another way of dividing the nucleus. This aim is to divide the nucleus in the bag. And just let us
so
see
that the pre-chopping in the bag becomes a little bit easier. I have a rhexis which is about 5.5 millimeter in diameter. This should be very comfortable for me to do the pre-chopping of the nucleus inside the bag. Time to divide the nucleus. I'm going.
So the OVD which I've used here is sodium hyaluronate because we want the chamber to be maintained when you're doing this maneuver. So I believe that using a heavier viscoelastic like sodium hyaluronate does have a role to play because it maintains the chamber when the
with my Chang chopper, which is introduced through the side port, whereas the Dr. Sohail Khan's pre-chopper goes into the main wound. The most intimidating aspect of surgery, especially for a novice surgeon, would be to introduce this chopper and hook the equator of the nucleus. So a stained capsule provides us excellent visualization so that we know that we are not over the capsule and we need to be under it. The chopper is slid horizontally so that the profile is horizontal now. And then in this profile, it is slid under the anterior capsule until it reaches the equator of the nucleus, and then it is rotated so that it goes in and hooks the equator of the endonucleus. So now we are sure that it is not above the capsule, it's under the capsule, and we can see the tenting above the anterior capsule, just confirming this fact. Now with the second instrument, that is a pre-chopper, it is going to be placed at the proximal end just beside the rhexis margin. The key thing here is that it has to be buried sufficiently deep enough. So the most important secret of achieving a good crack without inducing any torque, especially in such dense nucleus, is that both the instruments, that is the chopper at the distal end as well as the pre-chopper, the proximal end, they have to be engaging sufficient part of the nucleus. The Chang chopper has to engage the entire amount of the equator of the endonucleus, whereas the pre-chopper, it has to be sufficiently buried deep into the substance of the nucleus. And once we are sure that we are sufficiently deep enough, now is the time to move the instruments towards each other. And once it is done, we can see that the crack is done, but I'm not sure whether the posterior plate is also broken. So I just want to reconfirm it. I just rotate the nucleus a little bit and try to do the lateral separation using the same two instruments. I'm trying to place them inside the groove sufficiently and then try to separate them laterally so that whatever fine attachments are there holding on to each other, especially near the posterior plate, would be released. So in denser nucleus, it's obvious that the posterior plate could still be attached at some part, and go in, put in viscoelastic, and I'm trying to separate them using two instruments. OVD is introduced in between the two heminucleus inside the bag. This will help the bag to be well distended and the space is being maintained. Now is the time to prolapse each of these heminucleus out of the bag and then extract them out of the eye. Using two Sinskey hooks, I'm trying to manipulate one of the heminucleus out of the bag. As I'm trying to do it, I realize that there are still some fine attachments which are ensuring that the other heminucleus is also trying to come out. A little bit of manipulation with the two Sinskey hooks, followed by OVD injection, ensures that the two heminucleus are separated. Let me pause the video now and just wanted to highlight a point. Now, if we can see that the widest diameter of this heminucleus would be around 4 millimeter, and it would very easily come through 6 millimeter or 6.5 millimeter tunnel without any effort at all. We can just use visco expression also to pull this out of the eye. So the message here is that if we can manage to divide the nucleus inside the bag, each of the heminucleus would be measuring around 3 to 4.5 millimeter, which would be very easily extracted out of the chamber and out of the eye without any damage to the endothelium. So one can just go ahead and use an visco expression if he's not well versed with the introducing the vectors in the dialer. In this case, I'm going to do the routine, that is my routine technique of echo sandwich technique, wherein I go in with my Sinskey hook and the small vectors and sandwich the fragment in between these two instruments and pull it out. The OVDs again refill into the antechamber and the bag, and then the second heminucleus is manipulated out of the bag, and using the same two Sinskey hook, just holding on either side, I just pull it out. This was a very traumatic way of removing the nucleus out of the antechamber. The rest of the steps are quite routine. I'm going to do cortex aspiration.
So let me just show you another case here. So few important pearls here. We need to have a stained anterior capsule because we want to be sure that your the second instrument is going under the rhexis, not above it. What can go wrong here? If we place our horizontal chopper above the rhexis, we can cut through the bag. So it helps to identify that the chopper is gone underneath the rhexis margin. So that's the way to identify. So having a well-stained capsule is definitely helpful. And second, again, would be repeating that, preferable to use sodium hyaluronate, which maintains the chamber during these maneuvers.
Tempting to do hydrodelineation, but this is dense nuclear cataract, so there is no visible golden ring here because the epinucleus is quite thin here. The two instruments which I'm going to use again is the Chang chopper, which is going to hook the distal part of the endonucleus. And this is the Dr. Sohail Khan's pre-chopper, and this is going to be starting from the proximal end. The Chang chopper is tilted downwards and slid under the anticapsule.
So this step, most people find it intimidating. So the trick here is to, you have to just make it horizontal, slide it under the rhexis margin, and then make it vertical. Okay, so that it is going to hook the entire part of the endonucleus. So if you're going to hold only the superficial part of the nucleus, you will not achieve a full thickness crack. So the secret is it has to encompass the entire endonucleus. Then only you get a full thickness crack.
To go in and hook the equator. Once it is done, now I'm going to push in the pre-chopper down just at the end of the rhexis margin. So this is the distance which...
So again, the thickness which we have to go inside. Now this pre-chopper, it has got a sharp tip. We can go bury into the substance of the nucleus. So usually the length is about say 2.5 millimeter. So the average nucleus size of moderate thickness would be anywhere between 3.5 to 4.5. So in such situations, it's unlikely that you're going to go through and through. Anyway, at least 2 millimeter, it has to be buried inside so that you got sufficient purchase nucleus material. If you're keeping it too superficial, then you cannot cut the nucleus through.
Which we need to traverse to get the nucleus splitting. So care has to be taken that the chopper at the distal end has also hooked the entire endonucleus quite well. It is not just superficial scratching on the surface. It has to properly hook the endonucleus. And the second thing would be that the pre-chopper and the proximal end also has to be sufficiently deep enough. So once we are certain about this positioning, then the two instruments will be moved towards each other. Let's see how things turn out now. The movement is firm and slow, and suddenly I could feel the snap, which suggested that the nucleus is divided. So I come out, inject more viscoelastic, and try to inject viscoelastic inside the groove itself and try to separate it. At this moment, it looks that some part of the posterior plate is still attached. So I'm using 2 Sinskey hooks to gently go inside the groove and try to separate all the tiny attachments which could be holding on the posterior plate. Here I could see one area, and just gentle manipulation, they could be separated out. The next step is to remove these 2 divided heminucleus.
So I'm not a big fan of dividing the nucleus into multiple more fragments. My logic is that, when you do a temporal incision, even a 5 millimeter incision does not induce any astigmatism, sclerocorneal tunnel, if it is well constructed. So I would not want to divide into more and then maybe try to struggle to get into a smaller incision. Since this temporal incision is very forgiving and predictable as far as the surgical induced astigmatism is concerned, so I would not be so overtly enthusiastic regarding reducing the incision size. So anywhere 5 to 6 millimeters is perfectly fine for me. In this case, during the division of the nucleus, I've just made a 3.5 millimeter entry, but while extracting the nucleus out, I'm going to enlarge it to 6 millimeter. The reason why I made a smaller entry is because the chamber maintenance is slightly better when you're doing this dividing maneuver. So that's the reason.
Into the antechamber. Now, this is a slightly tricky situation because traditionally we are all used to rotating or wheeling out the nucleus. The entire nucleus moves out. This is relatively much more easier. But in this case, we have to remove these 2 pieces, and this has to be done without rotating. So there is a slightly different way of dealing with these heminucleus out. We need to remember that the cut surface also has sharp edges, and this could be traumatic to the endothelium. So when you're trying to remove out, it has to be very careful, and we should be mindful that these, if they wobble and they touch the endothelium, they could be causing some amount of mechanical damage to the corneal endothelium. The technique which I am using, proposing to be used, is that I'm going to use 2 Sinskey hooks, and it is like a chopstick maneuver. Using 2 Sinskey hook, it gently grabbed, and then one pole is pulled up, and then the entire segment is pulled out of the bag. So this I call as the chopstick maneuver. We're not rotating or wheeling the nucleus out. We're just holding it, gripping it, tilting one pole out of the bag, and then pulling the entire segment out into the antechamber. Once one heminucleus is out under the cover of OVD, I'm going to pull it out in a traditional way using the vectis and the dialer. The vectis which I'm using here is very small, so that it's just about 3 millimeter, so that it can really hold the nucleus well enough. If you use a larger vectis, then probably the fragment can slip under it. So I'm using a very small vectis to grasp it along with the dialer, like how we use for a phaco sandwich technique, and then it's pulled out. Again, viscoelastic is used to fill in the chamber. The second heminucleus is then maneuvered out of the bag using the same chopstick maneuver. OVD is put both in front and behind the nuclear fragment, and then using the phaco sandwich technique, the second fragment comes out. The epinucleus is removed, followed by aspiration of the cortex.
I think that was it.
A PMMA lens will be implanted. I'm asking my assistant to irrigate so that whatever blood is
So that was the presentation from my side. Thank you so much for your attention.
Fantastic videos as usual, Dr. Deep.
Thank you so much, sir. Just now we witnessed an array of videos and the surgical expertise, and the forum is open to discussion. And now I'll invite the discussants. First of all, I'll invite Dr. Kuresh Maskati for his opinions and comments as well as suggestions. Over to you, Dr. Maskati, sir.
Thank you, Rujita. As always, it's a it's a complete delight to see Deepak's videos and the amount of preparation that he goes, making it what I would call user friendly, so that even the novice can understand the finer points, and he drives it in so well, Deepak. And as you said, there are many ways to skin a cat. Once you've divided the ME nuclei, I think even a simple visco expression would just, as you rightly mentioned, would make your nuclear pieces walk out completely. But whatever the whole point of SICS is, in FACO, there's not that much variability. In SICS, for nucleus to come out, there are so many ways, and each one of them in an expert's hands makes it so easy. I mean, when Anil uses a snare, you think that the best way out is with a snare, till you see Deepak doing something like this. So all the take-home message is that whatever works well for you and whatever you see in a master doing and you can emulate easily, do it, because the end result will be best. Don't mess around with too many techniques, is what I would say. Amanjit, I was very impressed with your butter knife chopper, also the name you gave for it. I didn't get a glimpse of the chopper close up, because I think did you show that first?
Yes, I showed it on that, but it was with a very short period of time.
Yeah.
A
So
few seconds.
would love to see more of that
Sure,
chopper. Sir. What you do is that you chop it with the vectis as a support.
As a support, yes.
Yeah. So when you're cutting with the chopper, it is actually against the edge of the vectis, not the space between.
Exactly. Yes.
Yeah, because otherwise you would make it sink down. Yeah.
Yeah. It's at the edge.
So again, the compliments to you. I mean, both the presentations were excellent, and a lot of take-home messages for the audience. Thanks.
Thank you so much, sir. Thank you.
Now I request Dr. Pangarkar, sir, for his views. Please unmute yourself, sir.
Excellent videos, and each master demonstrated the different techniques of fracturing the nucleus to get out through a smaller tunnel, whether in the bag or outside. Deepak's is a very classical method, and the use of the Chang chopper and Khan's pre-chopper, excellent. I am also impressed with Dr. Amarjeet's, but maybe we could have had a better look at that, closer look at that butter knife. And of course, Vinayak Badge's the reminder of my Tashkent conference where Vinayak had presented this. Excellent thing, but it needs a lot of visco. But I think visco helps protect the cornea. Overall, whichever method you use, as Dr. Kuresh has very rightly said, whichever works best in your hands, and perhaps it needs at least, if not hundreds and thousands, at least 100 surgeries to master one particular technique and to stick to it. But hats off to each one of them. Excellent, short, very crisp, very to the point, and very effective communications. Thank you.
Dr. Parikshit, over to you.
Well, all of them had fantastic videos, but I think they should always show with a disclaimer that all these are in hands of expert surgeon, because they have so many instruments. Each one of them had at least 2 instruments going into the eye at any one point of time, which if it's a very hard nucleus, leaves a very little space for us to move around, and there is always a danger that corneal edema will result. And so, as Dr. Pangarkar said, we need a lot of visco or a AC maintainer to maintain it. Dr. Amarjeet said that we have to perhaps, do everything corneal, because sclera is something that scleral wound healing, we are not exactly sure of. That's great. But again, doing so many maneuvers through a smaller corneal is, I would be scared. And Dr. Amarjit Singh is, of course, he is a very dildar, what shall we say, a Sikh, and they have all very, large and very strong hearts. But then everybody doesn't have that strong heart, and the next day, everybody may not get that many crystal clear corneas. Dr. Deepak, of course, has fantastic teaching videos, and doing it in the bag is, yes, in that way, this SICS technique is then almost mimicking phaco, because in phaco also, all the maneuvers are done in the bag away from the endothelium, and that is what causes the early visual rehabilitation. But as he pointed out, that there can be sharp edges which need to be dealt with. So overall, so many new things. And again, what we say is, in manual SICS, there are so many ways of doing it. Each has its own technique. And well, we need more research, more publications to show that what works best in what hands and in what kinds of cataract, because with different kinds of cataracts, obviously different techniques would work. And once again, of course, congratulations to Dr. Anil Shah sir, Marathe sir, Dr. Aarti, Dr. Rujuta, because for I think almost 2 years together, they are putting this every month. Thank you for giving me the opportunity.
Thank you, Dr. Parikshit.
Yeah. Thank you so much, Parikshit sir. We'll take comments from our chairpersons as well. So we'll start with Dr. Ranjana Pandey ma'am.
Good evening. I have questions for Dr. Badgi sir. He is putting the Visco AC maintainer, which is from which port? It is another port or a routine side port?
Routine side port.
Routine
I have
side
two side ports.
Okay.
Two side ports and the main incision.
And it is a cannula of which bore? What is the size
21
of
gauge. 21 gauge Calvin set.
Okay, and the Caesar you use is a long, it is a long manas, I think.
No, I have designed it myself. I got it.
Achha, you have designed it yourself. Yeah. Okay, that was my question. And you have used the iris guard. Is it available in the market, and what material it is?
No, I got one special material from those who are expert in polymers. Then he got it done, and he told me that whatever for your autoclave it will be stable. So he gave me a sheet. Exact composition I don't know.
Does it? It doesn't traumatize the angle, because when you are maneuvering the nucleus, it is pushing in the angles, because it is a yes.
Yeah, but it stays because of the cushion of the viscoelastic.
Okay.
Sometimes it happens. Sometimes iris, so that edge, sometimes it causes a little bleeding.
Okay, sir. And to Amarjit sir,
yes,
your surgeries are all chops are done in the anterior chamber. Okay.
Yes.
So generally, for foldable lenses or anything, we need a 5.5 millimeter incision.
Yeah.
Not all nucleus will come out from the 5.5, because in SICS we generally go for 6 millimeter incision.
Yes.
And 6 millimeter incisions are not so good for foldable IOLs.
Correct.
So if the nucleus is bigger, then foldable IOL and SICS will not go, I think, hand in hand.
See, the concept is very simple. If your incision is less than 5.5 millimeter incision, the normal the IOL is not going to go in. It has to be folded somewhere. So the injector has to be used.
No,
now,
sir.
In all my cases, what I wanted to show you that in cases of bigger incisions, you get more astigmatism. So why we want to come in small, and if you want to make a small incision, the injector has to be used. There is no other way.
Excuse me, I forgot to tell you about the CCC margin. See, even CCC margin in SICS, we take a bigger incision, bigger CCC to take out the hard nucleus.
Yes.
And in the bigger CCCs, it is very difficult. The IOLs are not so stable. Foldable IOLs are not stable because of for 6 millimeter CCC.
Yeah.
Because when you are going for a phaco-like SICS, incision is okay, 3 millimeters. But if it's a grade 3, grade 4 nucleus, then you will have to have a bigger CCC.
Exactly.
And if there is a bigger CCC, because you are pulling the whole nucleus inside the anterior chamber.
Correct.
And then you are cutting it.
Yeah.
Okay. So the bigger CCC will be little problematic for foldable IOLs. This is what I feel, because then again there is a crumbling of the IOL, and that can happen.
There are so many studies which are there available as far as the shape and size of the rexes is concerned. But if you want to calculate it as far as the astigmatism is concerned, it's only 0.25 until and unless one haptic is in the sulcus, another is in the bag. Secondly, if the large incision, large rexes, if you make, I can understand because of the pressure, the IOL itself, it goes forward. Because of that, you may get little bit of spherical aberration.
Oh.
Not the